like this patient had a VT, sustained VT, so I tried to harm the patient and try to treat. If they present with STEMI and refractory angina, then I might try to do, and as I've said, the aim in scan is not to give TVS referral, just open the vessels. Try to get one grade high. If 0, try to make 1. If 1, try to make 2. And we don't mind putting patients' radial stenosis on less than 50%. So we need to maintain flow in this patient. Once the flow is maintained, in course of time, like 1 month, 95% healing occurs. So we need to have patients wait for time, and I think time is key. This is.
Last question. Any role of anticoagulation? Anticoagulation.
No, there's no role of anticoagulation and should not be, because these are hematopoietic will results sometimes.
Thank you. Thank you very much for the discussion. Now may I now request Professor Mir Jamaluddin sir. Sir is the Captain Director of Only National Institute of Bangladesh and have huge energy. Just finished the live case and now sir just rushed here for his presentation. So I will talk on the complication of radial access. The right talk in right person.
Energy comes from fuel, and fuel is a sky, and that sky in Bangladesh organized by Azam. So we are grateful to Professor Azam as well as the sky. I like to talk on complications of radial accesses. A few complications I want to show. I have new data shows that the radial approach is okay. Data shows that the radial approach is superior to femoral approach not only in terms of vascular complications and major bleeding events, but also in reducing all-cause mortality. You come and see ESC 2015, ESC 2017, and ESC 2018. All is in favor of radial access and class 1. And A is a scientific statement. An update on radial artery access and best practices for transradial coronary angioplasty and intervention in acute coronary syndrome. Radial first approach is strongly recommended in all patients, but a graduated level of center and operator experience is recommended before transradial approach is pursued in patients with acute coronary syndrome. Transradial access for percutaneous coronary intervention has gained popularity over the last few decades. Enhanced safety, reduced morbidity and mortality, as well as overall reduced procedural costs, and complication rates also are less. Access site complications, and there is some acute complication and there is some chronic complication. In acute complication, usually access site, there may be hematoma, there may be infection, there may be sheath artery mismatch, uncontrolled hemostasis, thrombosis, and in chronic case, radial obliteration is the main. But arteriovenous fistula or CV aneurysm, though very rare, but occasionally we see, and in our collection, one is there. And we know there are some radial complications, radial artery occlusion, perforation, spasm, dissection, CV aneurysm, sterile abscess, AV fistula, catheter key, entrapment, and arterial eversion, endarterectomy, radiation. And radial artery spasm, as we know, in different series, from 8.8% to 14.7% cases there may occur radial artery spasm, which is one of the enemy for the procedure. Predictors of radial artery spasm. And predictors, female sex, small radial artery diabetes, unsuccessful access at first attempt. If you do repeated attempt, then there will be chances of radial artery spasm. Here you see severe constriction of the radial artery lumen. And there may be different types of spasm. It may be diffuse, it may be focal, and it depends on the procedure. And radial artery spasm, how to overcome? This is very important for younger ones. We shall have to take much time and take sedation of the patient. First, bite is the best one, as because if you repeatedly prick the radial artery, you will make spasm. After puncture and difficulty in wire advancement, if you feel at all there is difficulty in progressing the wire or catheter, you will think of radial arterial spasm, and accordingly you will have to do, meaning that if you are with sheath, then you are feeling discomfort for progressing the wire or catheters, you will take a CNA with diluted dye and you will see what happens. And before it, you may use also vasodilator. Here you see the spasm. Seems to be the end of a long balloon. So much so spasm and tortuosity in what we have encountered. And how we have overcome it? After giving nitro or diltiazem verapamil does not improve, then we proceed with PTCA wire, and over the PTCA wire we do the bed, and after doing the bed it is crossed, and after doing the procedure, when we come back we have seen this is the scenario. So it has proved that that was the spasm. And this is another radial arterial spasm, and this was also taken with balloon assisted tracking. And after the procedure, we come back and giving dye and see the scenario. It has been dejected. Radial arterial occlusion. This is the most vital thing nowadays. Why we have away from the radial? Why we are looking forwards to the distal radial approach for seeing for avoiding the radial arterial occlusion. As we know, the radial arterial occlusion is approximately 3 to 10% in different series, but those who are doing distal radial approach, the DISCO radial trial is ongoing in 13 centers of Europe, and 13,000 patients is enrolled, and that study is going on. They want to show that distal radial approach reduces the radial arterial occlusion, and in our country we have started in 2017 and we are doing. And the utilization of appropriate anticoagulant, proper sheath selection, non-occlusive or patent hemostasis can lower the radial arterial occlusion. If we use bigger size sheath, then there is more chances of radial arterial occlusion. And radial arterial occlusion can be documented by ultrasound Doppler, post-procedural and follow-up. If it is essential to remember that the presence of radial arterial pulse does not rule out radial occlusion, as because the radial artery where we have done the puncture, at that side there is obstruction, but from the opposite side, meaning that from the ulnar artery, the radial artery is fed. So, radial artery palpable after the procedure does not always indicate that your radial artery is, there is no occlusion. And loosening the bandage or occlusion device after this is very, very important. We, the people who are doing the radial, all these sentences are for the younger colleagues, and we, the people who are doing the radial, we must have to be cautious to lose the bandage within 2 hours. If we do not do it, if we lose the bandage or remove the bandage after 24 hours, definitely we will lose the radial artery. In Bengali, radial artery অত্যন্ত সংবেদনশীল, very much sensitive. And radial artery perforation, this is another very important complication. Very occasionally we felt it. Here, predisposing factors of radial artery perforation. Here also the small radial artery in the elderly with tortuous radial artery, hypertensive patients, radial artery loop, inadvertently forceful manipulation of the guide wire and catheter, and reuse of catheter or diagnostic wire. This is also one of the important. And if the radial artery perforation occurs, how we overcome? Practically we press the cup, BP cup, and simultaneously we see the saturation on the hand. And radial artery perforation, you see this is here catheter is obstructed, and so we felt that something has happened, and we checked with diluted dye, and this is the scenario, meaning that there is radial artery perforation, and then we have exchanged with the PTC wire, and over the PTC wire, doing the bed, we cross the lesion and do the procedure. Angioplasty has been done, and after angioplasty, we once again check the. This is another case. This is another case. After angioplasty, that we have checked, and that was completely recovered. Meaning that inside the artery, if your catheter is there, and over the forearm, if you have tough pressure, so from outside pressure, from inside pressure, and catheter itself acts as a healer. And this is another very dangerous perforation. And after doing the procedure, this is the result. You see there is no perforation. The perforation becomes sealed. And perforation distal radial, very rare. But as we are doing distal radial in our country, so this is one complication what we have seen, and we have done it by then conventional radial, and over the distal radial, simply by 2 fingers compressing, it remains normal, meaning that it has been closed. This we have also crossed, and after doing the procedure, this is final, there is no perforation. There may be radial artery dissection. The radial artery dissection, it does not move, so I can show it. And there is pseudoaneurysm. Pseudoaneurysm, this is our picture. The pseudoaneurysm can also happen, which we have treated with ultrasonic compression. And this is another pseudoaneurysm. This is another pseudoaneurysm. And pseudoaneurysm closure, tear band also we can use, but we do not usually use tear band. And this is the most new complication in our center. We have seen this case, distal radial approach, but there is a pseudoaneurysm. And this is not ever seen, and this is the first time we have seen. And patient came after a few days, and that is why we did not able to compress it by ultrasonic compression, and it required surgical maneuver. And arteriovenous fistula, this is very also rare, but out of several thousand cases, I have found only one case. And this is hematoma, bandage with forearm and hand hematoma. You see the hematoma extending up to the arm. Always we should check the oximetry, as because whenever there is hematoma, whenever there is compression for the radial artery to give, then we shall have to check the oxygen saturation of the thumb or middle finger, index finger. And hematoma in distal radial axis also, there may be occur. And this is infraclavicular hematoma. This is not our case, this is from book. And this is our case, depigmented scar on the forearm. This is our case, minor hematoma with blister formation. Minor hematoma with blister formation. And this is looks very ugly, you see, infected at the puncture site. And you can compare with both hands. And the radial artery is an excellent, I have taken it very small presentation, as because it is the almost last hour of the 2 day at the end of the day, so I have made it smaller. The radial artery is an excellent access site for coronary intervention, although there is a definite learning curve, and complications are not frequent, but many are preventable with adequate planning and careful technique. Thank you. Thank you.
Thank you very much for very elaborative and very illustrative presentation, sir.
The question. You have shown 3 cases which are from the radial approach, but need no treatment. Is there any situation we have to treat otherwise?
And perforation, radial artery perforation needs no treatment, meaning that needs no intervention. If there is perforation, we shall have to treat. How we treat them? We treat them by giving the blood pressure cuff over the radial artery, meaning that at that part where perforation has occurred, and alternately few minutes remains inflated and few minutes deflated, once again few minutes inflated and another few minutes deflated, and by this way after if you do for several times it will automatically heal. And besides that, what I have shown that